College of Pharmacy here at the University of Michigan, and I'm a clinical pharmacist in pain and palliative care. I practice both in the inpatient setting and in the outpatient setting, seeing patients with various pain conditions. So the objectives for this talk are to recognize the wealth of non-opioid medications available to treat pain and match medication class to pain mechanism. What I frequently do with learners or with providers is I talk about alternatives. What we often get into when we manage any sort of condition is to get comfortable with a handful of medications, know when to use them and know when to not use them. But unfortunately, when you manage pain, if you're only stuck using a handful of medications, this leaves you in a tight spot where you may not be using the best medication for whatever that patient's pain condition is. So what I often do is have providers or learners name as many medications as they can to treat pain. An example here will come up in a moment, but take a second to think about how many medications you can name that'll actually treat pain. So I would recommend you hit the pause button and go back and do this before I show you the actual table. Here are over 40 medications that are used to treat pain, and there are many more than this. This is just an example of how many there are available to us. And what you'll notice on this slide is not one of these is an opioid. So we have plenty of medications within our armamentarium that we can use to treat people with pain. Now, the important part of this is to recognize when those medications are appropriate for various pain conditions. So as an example, in the right-hand column, all the way at the bottom, you'll see the triptans. These are simply for migraines, so you would need to understand that those medications are just for migraines. They're not necessarily going to treat other pain conditions. The first column is really our NSAID group, and those are used to treat a specific type of pain, and we'll go through that. But whenever you're talking to patients or you're trying to talk to providers, it's important to understand how many medications you actually have at your disposal and what medications patients have tried. It's really important to understand their past medication trials because that'll impact their response and your medication selection or recommendations. So when we simply just talk about non-opioid classes of medications, you can still see that there are a large number of classes of medications that we often don't use. We frequently see Tylenol and NSAIDs, but outside of that, many providers are not necessarily comfortable with the large number of medications that exist in other classes and may not necessarily understand, nor do patients understand that they have a wide variety of medications that are available to them, each with their own benefits and risks. I had mentioned earlier it's important to understand that each medication is going to work for a certain pain condition. You have to understand how, at least in a basic sense, these medications will work. So on this slide, they're generally organized by their mechanism. And so what you can see, as an example, the NSAIDs and corticosteroids are anti-inflammatories. So these are medications that would be helpful for patients that have any sort of inflammation with their pain disorder. If you think about kind of a classic example, think of a fracture or a sprained ankle. There's a lot of inflammation with that process. NSAIDs would be very effective for that type of pain. When we go to the next example, TCAs, tricyclic antidepressants, and SNRIs, these increase norepinephrine within the central nervous system. So what they do is they work by helping the descending pain pathway, helping the patient's body re-regulate how they process that actual pain. So those medications aren't necessarily going to be effective for other types, and we'll look at that in just a second here. But it's important to at least have the classes behind what you're doing, because when you're treating pain, you should be matching how does the medication work with how does the pain actually happen. Then think about the data that's behind it. But if you are at least using your background understanding of those two key factors, you're more likely to select a medication that's going to be effective for a patient. So when we talk about this is a handy little chart that tells you what is the type of pain and whether or not a medication is expected to work for that. So we'll go through each of these, and that doesn't mean necessarily that if this patient has this type of pain, they absolutely should get this medication. It means that we would expect that this medication would work for that type of pain, you then have to take into consideration their other medical conditions as to whether or not that medication would still be appropriate. But in general, this chart lays out for you what we would expect of medications. So as an example, peripheral nociceptive pain. The example I can give you here is an injury. You can consider this injury a surgery. You can consider this injury a fracture, a sprain. You could consider this injury cancer. We would expect that based on how that pain works within the body, that the first three drugs listed there, classes listed there, acetaminophen, your anti-inflammatories, and then the drugs that increase norepinephrine like SNRIs and TCAs to help with that type of pain. Now, those medications may be effective in the short or the long term. That is dependent upon how those medications act. As an example, anti-inflammatories will work quickly but can also be used in the long term. Whereas our drugs that increase norepinephrine, they take a longer period of time for patients to see benefit. So if somebody comes in with a fracture to the emergency room, we're not going to give them a medication like duloxetine and expect that to treat their pain. But if they have a nociceptive pain, that's a chronic condition, I'll treat that with a medication that's used chronically, such as duloxetine. If we look at our second column here of pain types, this is neuropathic pain. You can classically think of neuropathic pain as a diabetic neuropathy. So this is just nerve pain. And so the medications that we think that will work for nerve pain based on their mechanisms have the green checks for you there. Some other examples, since we've already talked about drugs that increase norepinephrine, are calcium channel blockers. So this would be gabapentin and pregabalin. And so what those medications do specifically is along the nerve route, they are decreasing the signal that's being processed along. So that helps slow the pain processing pathway. It works directly on the nerve endings that are receiving those pain signals. So when those nerves are damaged, we would expect that medication to work. On the flip side of that, as an example, an anti-inflammatory does not work on the nerve pain. The only exception to this working for nerve pain is if there's some sort of compression or inflammation that's causing compression upon a nerve, that might help, but it's not actually directed at the nerve pain itself. And then finally, the last column here for you is centralized pain. Centralized pain, the classic example that you can think of is fibromyalgia. And really what these pain conditions are is that there's not actually, the pain is out of proportion from any physical exam findings. What the patient experiences is absolutely real. What they feel is real. They have a legitimate reason for having pain, but certain medications are going to make that type of pain worse based on how it processes in the body, and other medications are going to make that pain better. As an example, for fibromyalgia, we know that opioids should not be used for patients with just fibromyalgia because of how opioids stop the pain processing within our body. It does not allow patients with fibromyalgia and this centralized pain to help modulate their pain processing signals. So we look at other medications that may be helpful for patients with centralized pain. You could look at things like sodium channel blockers, which are things such as lidocaine or anticonvulsants. We could look at NMDA antagonists such as ketamine. And not that we're using these things frequently, but these are options that are available to our patients. And even things like cannabinoids, they may be effective for patients with centralized pain. So when you're taking a look at patients with pain, it's important to understand how their pain is actually processed within their body and make sure that the medications that they are offered match with how that pain works within their body. And so you should start wide and then bring it back in based on, do they have a medical condition that contraindicates this medication? Is this medication too costly for them? And then find what is the best medication. So if you're trying to help patients and providers decide about what medication to use, giving a larger list and whittling down is a much more effective strategy to make sure that we don't miss medications that would be effective, rather than starting with the first 5 that we know and go, none of these will actually work. What's another one? What's another one? We're not giving ourselves all of the options. We're not providing patients with as many options as we possibly can.